All right, then. Moving on from polyps, we're going to talk about colostomies. Colostomies can either be in the ascending colon, and that is done for right-sided tumors. It can be transverse, is often used in emergencies if there is an obstruction of the bowel. Perforation, because it can be created quickly. There are often two stomas, one proximal and one closest to the small intestines that drains the feces. The distal stoma sometimes will drain mucus, especially if the reason for it is because of the obstruction. There's usually mucus buildup ahead of where the obstruction actually was. And then they would go back in and fix this later, either making it into one colostomy, one stoma, or hopefully be able to reverse the colostomy completely. Descending colon, they're done on the left side, and a sigmoid colon is done for rectal tumors. Alrighty then. So, of course, there's a video on the My Courses page that you watched prior to your new skills. Colorectal refers to both the colon and the rectum. Colorectal cancer is cancer in the large intestine. Major risk factors include being over 50, genetic predisposition, Crohn's disease, ulcerative colitis. Other risk factors include long-term smoking, obesity, physical inactivity, and heavy alcohol consumption. Assessment for GI history, make sure you look at page 1128. Most common signs of colorectal cancer include rectal bleeding, anemia, and a change in their stool consistency or shape. You want to make sure you look at table 56-2 for the pre-operative care for these patients as well. Colostomies are often done for both colon cancer and may be extensive and may be repeated for bowel resections as well. They can be both temporary and permanent. The pre-op assessment done by a stoma care nurse is done prior to surgery, and you won't really be responsible for that information, but I do want you to have read through that and know what an ostomy nurse would be able to do for your patient. And when you're doing your patient teaching preoperatively, you want to make sure that you have gotten the ostomy nurse up to see the patient to talk about care prior to the surgery. Postoperative care usually includes being NPO until their bowel sounds return. Many times they have an NG tube. They may come back with a clear pouch in place. And a pouch is similar to an appliance, but the difference is it may just be one that is not going to be the one that they're going to be using all the time. It's usually just we call them surgical pouches, where they aren't the clip-on kind like you learned in your class. It's more just a stick-on, and it's clear so that you can see the stoma. It's not the tan-colored that a lot of them are. A normal ostomy should be reddish to pink in color, and it should be moist. They usually start functioning on day 2 or 3, but you may start seeing, as soon as the patient starts to have bowel sounds, you'll start seeing gas in the ostomy bag, and you'll need to burp the bag to allow the air to escape. And you want to do that because if you don't do it often enough and the bag gets large, it can mess up the seal on the bag, and then you have trouble with leakage. So you really want to make sure if the bag needs to be burped that you do that. Remember, if it's from the ascending colon, it's more liquidy. Transverse is more pasty. Descending is more of a solid material. And these patients usually can return to their normal activities in 1 to 2 weeks. I do want to make sure that you look at the chart 56-6 for home care of the patient with taking care of a colostomy. There's so many different ways that people are taking care of colostomies today, but it is important to know how that they need to care for them at home and how they are cared for in the hospital. A lot of times, if you're taking care of a patient and they have a pre-existing colostomy, they'll pretty much take care of it themselves or be able to tell you what needs to be done to care for it. Colostomy care, you want to make sure that you have normal appearance to that stoma, that it's a reddish pink color, that it's moist, that it's outpouching. You want to make sure that you need to know the size of the stoma. It may shrink some operatively as the swelling decreases. The ostomy care nurse will help to choose what type of appliance will be most appropriate to cover the stoma and what's most appropriate for the patient to be able to care for at home. So that's really where the ostomy and wound nurse comes in and is more helpful in that, getting them with their appropriate appliance to cover the stoma for home care. You want to make sure that you're taking precautions to protect the skin, not only from the gastric secretions, but also from the adhesive that is used. There's stoma paste that helps to protect the skin. Dietary measures are used to control gas and odor. The patients just kind of get an idea of what they can eat that doesn't cause the gaseous problems and doesn't have as bad with the odors as well. A lot of times these patients have huge body image issues, especially if they're very young, females more than males, but anyone can really have the body image issues. And this is where the wound nurse can come into play, help them with different ways to hide the colostomy. There's actually clothing now that's meant that especially made to help to hide the colostomy inside of formal wear and tight-fitting clothing. So there's all kinds of different avenues now that the patient can have. The big thing as the nurse during this recovery phase is to listen to the patient's concerns and to find out what their concerns mostly are. Oops. Sorry. So concerns about ostomies can be coping. Again, we talk about the wound nurse helping with making sure that the appliance that is used is something that the patient's able to do, especially if they're elderly or have poor dexterity. A lot of times there's a lot of denial and anger. They really sometimes will actually mourn the ability to have a normal bowel movement and dealing with the ostomy, especially if they're dealing with cancer as well. They're going to learn to avoid foods that increase gas production and odor. They'll learn how to keep the stoma clean. That's what the ostomy nurse will do, teach them how to care for it. Looking for signs of infection, making sure that they are not getting constipated. You want to make sure that they keep any hair around the area clipped, but you don't want them to shave it because you don't want to accidentally nick the stoma or nick the skin around the stoma, which gives that an avenue for an infection. This is one of the appliances that can be used. It's called a stealth belt, so that the person can wear a more form-fitting outfit to hide their colostomy bag. And there's all kinds of different things out there now to help with camouflaging the ostomy bag. Oops, didn't mean to go forward, sorry. Alrighty then. Alright, let's move on to irritable bowel syndrome. It's the most common digestive order. 1 in 5 people in the U.S. have some form. Irritable bowel syndrome D is diarrhea. You can read through those. The etiology is unclear. It is also sometimes referred to as spastic colon, nervous colon, or mucus colon. But irritable bowel syndrome is the big name, and then the different letters, or whether it's diarrhea, constipation, or whether it alternates between diarrhea and constipation, or whether it's a mix of diarrhea and constipation. Again, the etiology is unclear. It's thought that it could be environmental factors, immunological ideas, stress, hormones. It could have a genetic factor. There is thoughts to stay away from caffeinated beverages, dairy, uncarbonated beverages as well. Small bowel flora overgrowth causes bloating and abdominal distension. 2 to 1 in the U.S. is women over men, but that is not true in other regions of the world. Irritable bowel assessment, you're looking for weight changes. You may or may not have them, but especially if they're having a lot of the diarrhea problems, or sometimes they choose not to eat at all because then they don't have the problems. They a lot of times will have fatigue and malaise. They'll have abdominal pain, the changes in their bowel pattern, and what causes those changes. Like, is it a stressful environment? Is it when they're having a test at school? Is it, if they have a fight with a loved one? Or is it not related to that? Is it related to foods? So you just need to kind of get that idea. Is it being caused by some medication they're taking? You want to see what their nutritional history is. Are they eating a lot of fructose or caffeine? Or sorbitol, which is the alcohol sugar, can cause a lot of diarrhea and irritability to the bowel, and it can act as if it is irritable bowel syndrome, but really it's just a side effect from the sugar alcohol. You want to make sure you do a thorough abdominal assessment, and you want to ask if they have nausea with eating or nausea when they are defecating. Some nursing interventions include health teaching, such as they need to be on a 30 to 40 gram fiber diet. They need to have 8 to 10 cups of water a day. They need to eat regular meals. They need to make sure they're chewing their food thoroughly and slowly, and try to promote normal bowel function. Their treatment for therapy can be different medications. As you can see, some of them are just antidiarrheals. Then you also have rifampin, and you also have amitriptyline as well. And all of these can sometimes assist in the caring for the symptoms. Again, the drug therapy is symptom specific. Also, sometimes stress reduction with relaxation, meditation, and yoga may be helpful for the patient with irritable bowel syndrome as well.